perspective. Paranasal sinuses are air-filled extensions of the nasal cavity, as all of you know, and they are four pairs, as namely frontal, ethmoidal, maxillary, sphenoid, and maxillary sinuses. They are located around the nasal cavity. Development of the sinuses are growing, they are enlarging by age. At birth, they are rudimentary or sometimes absent. Their enlargement rapidly increase during 6 or 7 years of birth, but still in elderly, with the resorption of the cancellous bone, they still may enlarge. So there are some discussions about their function. Are they like accessory spaces, or actually we can say they have functional contributions to the olfaction, humidification and warming of the inhalation, and impact on voice resonance. And also their structural laws is the reducing of the weight of the skull. And they have some immunological function, as they all covered by mucosa and mucosal immunity against pathogens. So I will start with frontal sinus. Frontal sinus is located in the frontal bone. It's between the inner and outer tables of the frontal bone, just above the orbit. The frontal sinus is variational, and both left and right sides can be variational among individuals or in same person. Also, they are asymmetrical. Here in yellow, I highlighted the frontal sinus. This is the sagittal section of frontal sinus in cadaver, and you can see its close proximity, its relationship with the nasal cavity. So, as I mentioned, its anterior wall is created by the outer table of the frontal bone, and posterior wall is inner table of the frontal bone, which separates the sinus from the cranial cavity. Its floor, it's a thin bone. It separates the sinus with the orbit, and the medial wall of the sinus forms a septum between two sinuses. The frontal sinus is drains to the middle nasal meatus by the frontonasal ductus. It has very variational anatomy among individuals, and this is important for us, especially when we are preparing for transcranial surgeries. Also, there are some research about that, and it's found like the frontal sinus is usually larger in male patients. This is anterior cranial fossa of a cadaver, and when we open the superior inner table of the frontal bone, we can see here the frontal sinuses and their relations with the orbit. Its innervation, it comes from the supraorbital nerve, and its blood supply comes from the supraorbital artery. And here, as I mentioned, you can see the ductus frontonasalis, which drains the frontal sinus into the nasal cavity. Why frontal sinus anatomy is important for us? Like I said, when we are preparing for surgeries, for example, aneurysm clipping or bypass with supraorbital craniotomy, or when we approach for big tumors like olfactory groove meningiomas, preoperatively studying this patient's specific anatomy is important to tailor our craniotomy and approach. The second sinus is ethmoid sinus. There are air cavities in the lateral muscles of the ethmoid bone. Their roof is nearby the anterior cranial fossa and lateral to the cribriform plate. In its lateral wall, the orbit, optic nerve, and lacrimal duct locates. Inferiorly, it has relationship with maxillary sinus, and sphenoid sinus is located just posterior to it. In medially, its superior and middle turbinates creates its medial wall. The ethmoid sinuses divide into three different groups, which are anterior, middle, and posterior cells. The anterior and middle cells drain to middle nasal meatus, and posterior cells drain to superior nasal meatus. It's very variational, and it's very complex anatomy to master it. The neurovascular supply of the ethmoid sinus, it gets the anterior cells gets neurovascular supply from anterior ethmoidal nerve and vessels, while middle ethmoidal sinus gets supply from anterior nerve and vessels, and also branch from pterygopalatine ganglion. Posterior ethmoidal cells gets innervation and supply from posterior ethmoidal nerve and vessels, and some branches from pterygopalatine ganglion. Here I want to show a different perspective of the ethmoidal sinuses. You can see here a cadaver. These are the orbits, frontal bone, nasal bone. When we remove the nasal bone, we can see here the ethmoidal air cells bilaterally. And this is, as you see there, medial to the orbit, lateral to the middle nasal concha, and the sphenoid sinus just posterior to it. This is inferior view of the ethmoidal sinus. It's in a cadaver, it's like in maxillary sinus level axial cut, and we are looking from inferior. And here we can see the sphenoid sinus, and just anteriorly we can see the anterior, middle, and posterior group of ethmoidal sinuses. Why we should learn about ethmoidal sinuses? We are using transsphenoidal approach in many of the cases, and now we are seeing very good articles, research from from experts. But transethmoidal approach is still being in progress, and it's now being used like transnasal, ethmoidal approach to the especially medial nasal cavity and skull base. Sphenoid sinus, it's it's located at the sphenoid bone. In its superior, there is a pituitary gland and optic chiasm, and the olfactor bulb, and the frontal lobe. In its anterior wall, ethmoid bone and sinuses, and its lateral and superlateral wall, there is optic nerve. And its lateral wall, there is cavernous sinus, internal carotid artery, and third, fourth branch of the fifth and sixth cranial nerves. In its posterior wall, we can see the clivus and the basilar artery and brainstem. And here, an example of its lateral wall, there is carotid artery. This is summarizing the lateral, the structures located in the lateral wall of the sphenoid sinus, which are the optic nerve, the third, fourth, first and second divisions of the fifth nerve, the sixth nerve, and third division of the fifth nerve. When we use transsphenoidal sphenoid sinus anatomy is important for us in endoscopic endonasal transsphenoidal approach. So when we introduce the endoscope to the nasal cavity, you can see here in a cadaver left nostril approach, middle and inferior turbinates, and nasal septum. So we go superior and deeper, and we can see the superior turbinate. Sometimes there are, in some patients, there can be variations as called supreme turbinate. The sphenoid we found by guiding this superior turbinate to find the sphenoid ostium. I'm passing this speedily because Dr. Khan is very good explaining this portion. When we find the sphenoid ostium, we get here from the mucosa to reach the sphenoid sinus. Here, mononostril approach, and now with binostril bilateral approach, we can see here the anteriorly there is sphenoid rostrum, and we can see here the optic canal and lateral opticocarotid recess. When we remove the rostrum, we can see bony laminas here, which is different in each patient. And in the lateral wall, the optic canal and lateral opticocarotid recess and sella. We should study the cella anatomy for each patient with paranasal sinus CTs. This is because of the sphenoidal segmentations are different in each individual. And sometimes these bony laminas can guide us to laterally, which can cause some complications. After we remove the bony laminas, here we can see the sella, and the internal carotid arteries are lateral, and this is the clival recess of the clivus. In the next step of the transsphenoidal and pituitary surgery, we remove the bone of the sella, and there is sellar dura. And here we can see laterally the venous plexus of the cavernous sinus. The chiasmatic sulcus of the optic chiasm is located just superiorly. And after we open the dura, here we can reach the pituitary gland, and we can manage the pathologies located there. Also, we can reach the posterior lobe of the pituitary gland. We can also use this corridor to reach the supra or infrachiasmatic corridors. We use this prechiasmatic sulcus. There is inferiorly medial opticocarotid recess, which we should be careful when we remove this bone. After we open this, after we remove the bone, there is a prechiasmatic sulcus dura. And at the next step, after we remove the dura, we can see here the optic chiasm and optic nerves. And here is the optic canal, medial and lateral opticocarotid recesses. And if we introduce the endoscope, here we can see the suprachiasmatic and infrachiasmatic areas. Also, we can use this approach, this corridor, this sinus, to reach the planum sphenoidale pathologies. And planum sphenoidale bone, it's just superior to the prechiasmatic sulcus. And after we remove this bone, we can see the planum sphenoidale dura. And after we open the dura, here is the frontal lobe, gyrus rectus, and vascular structures. This is a summarize of actually sphenoid sinus. Here is the pituitary gland, infundibulum, and laterally located carotid arteries, here optic nerve. And this slide summarize the structures surrounding the sphenoid sinus. Maxillary sinus is its anatomy was uh, first defined by Nathaniel Highmore in 1651. That's why it's also called antrum of Highmore. It's located at the fossa canina of the maxillary bone, and it is the largest sinus and with pyramidal shape. The pyramidal shape, its base looks corresponds to the medial nasal bone, and apex comes to the zygomatic root. It is also the first developing sinus in the fourth gestational week. Its boundaries lie in the roof. It's close. It related with the orbit and infraorbital neurovascular complex. In its floor, there are close relationship with alveolar dental roots and alveolar process of the maxilla. In its posterior wall created by zygomatic and sphenoid bones, and we can reach infratemporal fossa here, and medially the nasal cavity. Its neurovascular supply comes to the arterial supply comes to branches of the maxillary artery, which are posterior superior alveolar artery, infraorbital artery, and descending palatine artery. Its innervation comes from branch of the maxillary nerve, which are middle, anterior, and posterior alveolar nerves and infraorbital nerve. Here in a cadaver, we see inferior view in axial cut of maxillary sinus and its close relationship with its medial wall with the nasal septum. And here is the orbit, and these two asterisks corresponds to the infraorbital neurovascular complex. Maxillary sinus, interestingly, it's been using more than 100 years by ENT surgeons to treat different pathologies. But interestingly, the intraorbital lesions, it's not used for treatment of intraorbital lesions until recently. In 1998, Canardel has introduced a sublabial transmaxillary approach to orbital pathologies. After his introduction, only a few case presentations are used, and interestingly, it wasn't used for orbital pathologies. However, as I said, it's close relationship with the orbit as it covers inferior wall of the orbit. It's also possible for orbital lesions, and I want to extend this portion of the topic a little bit. I want to show on a case how to reach the inferior orbital floor and remove lesions of the inferior orbital aspect. The patient is similar position to endoscopic transnasal surgery here. We use a above the tooth line, just leaving a small mucosal cuff, a small incision, starting from the frenulum until the second or third molar. After we dissect this mucosa, it allows us to reach anterior wall of the maxillary bone. It's also called fossa canina. And there we should take care of the infraorbital neurovascular complex which exits from the infraorbital foramen. Also, inferiorly, dental roots, we should take care of them, because when we perform a maxillotomy to reach the maxillary sinus, we shouldn't damage the dental roots. After we remove the anterior wall of the maxillary sinus, the orbit is directly visible. This is in this patient, the mucosa of the maxillary sinus is removed, and here we can see the inferior aspect of the orbit. This is the floor of the orbit. After removing this part, it's easily accessible for these lesions. And this the bone defect of the orbital floor can be repaired by some materials like synthetic bones. At the end of the surgery, after achieving the hemostasis, the maxillary bone can be placed anatomically. I studied on maxillary sinus on this approach, sublabial transmaxillary approach, and during that period, after I noticed that this natural anatomical cavity is not frequently used by neurosurgeons, there was like one possibility to, we don't know its anatomy well. That's why we are less using this natural anatomical corridor. So to address this issue, we described a solution like some segmentational process, and achieving three-dimensional models can address this problem. And in a model, you can study first surface anatomy. You can perform any kind of bone removal to study the anatomy of the maxillary sinus. Also, from virtual model, you can create also using 3D printers a physical model. You can simulate some surgical steps and check the anatomy of the approach. I want to show this in one case. This is a 34-year-old male, right-sided exophthalmos and visual problems. And here we see a lesion inferior to the optic nerve. This is three-dimensional view. It's from superior, lateral, and inferior views of the blue tumor. This is the visual field test in the affected site, in the lesion side. So like I said, it's the patient's placed in supine position, similar to the endoscopic transperineal surgery. After the incision, we dissect the anterior mucosa to expose the maxillary sinus. Here, piriform aperture, medial wall of the maxillary sinus. And we are doing maxillotomy to remove anterior wall of the maxillary bone. And then we reach the nasal, the maxillary cavity, maxillary sinus cavity. After removing the mucosa, here we confirm our approach and the infraorbital neurovascular complex by neuronavigation, and also, as you see, easily we reach the orbital floor and the lesion. So after removing the orbital floor bone, here we expose the periorbital fascia. We extend our bone defect. We can extend if required with using Kerrison rongers. This is the periorbital fascia. As you see here, this natural anatomical cavity easily allows for access this orbital pathologies. Here, after we cut the periorbital fascia, the inferior rectus muscle, the periorbital fat tissue, And inside the fat tissue, we can see this lesion. We dissect the lesion, and I will just speed up this process and remove it with the big lesion and attached to the surrounding tissue. Hemostasis after removal of the lesion. This is endoscopic view of the maxillary sinus cavity. It's also this approach can be performed with only endoscopically. Case I am showing, this is a microsurgical case. Intraoperative MRI confirmed the resection, and we repair anatomically the orbital floor. We can suture the periorbital fascia. And reconstruct the orbital floor. After placing the maxillary bone, we can close the patient. As a conclusion, anatomy of the paranasal sinuses are variable. The sinuses enlarge by age. Neurosurgeons must understand this anatomy to perform complex procedures or adopt new techniques. Sinuses are key pathways in skull-based surgeries requiring precise navigation to reduce risk of complications. Detailed imaging and understanding sinus anatomy enhance surgical safety and outcomes, and this reduces the risk of CSF leaks. I would like to thank Dr. Güngör, who helped me in this presentation. Thank you.
Yucel, excellent presentation. Very good. I would, I mean, this is a completely new approach to the orbit, the sublabial transmaxillary approach. Excellent. Very good presentation. Now I'll call upon Amit to have his presentation. I know Amit from a long time.